very much. Last but not least, so that's the fourth unit, and it's a really great pleasure for me to introduce the unit. My name is Boris Michał, and I'm the lead of this unit. So moving to a bit more colorful picture. So that's where we are. So the unit was established last year, 2022, but the team, so there have been health economists at Queen Mary over the last probably 25 years, but there haven't been that many. So from 2018 to now, we've expanded from about 2-3 people to 13 people at present that we're recruiting. So if you know about good health economists, do point them to our way. So we have 13 people at the moment. 2 of them are one part-time, one full-time PhD student, and we have a third PhD student joining, which is joined with the methodological research unit, as you heard. So that's our faces. Most of us, only one missing, but I've managed to find most of the photos. So we're a young team, and we're still developing. So why health economics and why we've grown so much? And it's not only us. I mean, health economics units have grown in many other places as well. And the reasons are twofold. First, we are really addressing or contributing to addressing 2 of the main goals of all health systems around the world. The first is to improve efficiency in using limited healthcare resources. And the second is in improving or reducing inequalities that are unacceptable in society, such as by socioeconomic deprivation or by sex, by age, by ethnicity, and so forth. And health economists, what do they bring? They bring the theories, but they also bring new methodologies. And often, as in other sort of areas, health economists need to, to simplify the theories, to be able to practically advise policy. And for example, I'll talk about our areas, but economic evaluation is one such field where we started with quite complicated theory about maximizing welfare, and we ended up with maximizing qualis in the health systems. So this is just an example. So that's what we bring. We bring methodologies and try to help sort of tease out what interventions might be better than others, what are the best ones probably in certain areas, and how these impact potential inequalities. So, and we've grown because first we are addressing important areas and goals, but second is because we are really needed. Actually, we're asked to do it. So it's not that we sort of are there and trying to put ourselves forward, but we are increasingly asked to do this work because our results are used practically. They're used to prioritize interventions in health systems in UK and worldwide, increasingly so. So the demand is really very, very good. Okay, so what do we do in HEPRU? So our work spreads across 4 broad areas of methodologies. When I say methodologies, we develop some, we contribute to the development of methodologies, but we also apply them. So these are these 4 areas that we work on. First is economic evaluation, which is a sort of comparative framework that compares interventions and to try to tease out which one is best value for money. So have sort of the lowest cost per extra unit of benefit to the society, such as quality adjusted life year. So usually economic evaluations are developed alongside comparative studies, but they can be developed across different study designs as well. But they're usually based on individual participant data, one way or another. The second area of work is decision analytic modeling, and that has come forward because our theories say that we need to evaluate all possible benefit of the intervention, meaning not only within the first few years, which is what we at the best case we receive from trials, but also often over people's lifetimes. And to do that, we developed very involved frameworks or models to try to tease out, to bring together evidence, which we sort of synthesize together in this modeling framework, and to try to set what might happen over long periods of time. And one of the examples you'll hear more about it is in that vein. So the third area of work is health outcomes, in particular quality of life, because health economists have come with this sort of comprehensive, in brackets, outcome measure, which we call quality adjusted life year. Length of life is reasonably clear. Quality of life is less so. So that therefore we develop these suites of instruments or questionnaires to try to evaluate the best way we can the sort of broadest aspect of quality of life of people under particular health states or health situations. Okay, and the fourth area is what we call health policy evaluation. And it is sort of similar to economic evaluation, but the difference here is that health policy evaluation usually happens at system level. So we cannot quite randomize the whole system, or at least not very often. And therefore, sort of the health policy evaluation comes with slightly different analytical approaches to try to get as close as we can to pseudo-causal sort of estimates. So these are our four broad areas of methodologies we employ in addressing different questions. And in terms of unit, we address questions across very many different areas. And I have summarized here what we call key clinical areas. And they are here on this list only for one reason. We have more than 2 more projects in those areas, okay? So within the unit, we have 2 more projects. And you can see the list is broad, and Jan will talk about the mental health portfolio, and you'll see some of those portfolios are pretty large, some are small but growing. But generally, it is quite a vast portfolio we have in the unit. Okay, so in terms of what more I wanted to say before bringing my 2 colleagues who will present a little bit more details is that our work really spans lots of areas. It's very collaborative in nature, but we do have our own sort of lab projects as well as many collaborative projects. And that's the way we try to develop as a unit, to try to use our portfolios of work, all types of work, to try to develop the unit, the group, the people, and to develop strong research. So we're here really to help others, but also here to develop our own sort of research strengths and ambitions and so forth. So we invite collaborations, but do keep that in mind. So we do want to grow with you, okay? So, and here I will stop and will pass to my colleague, Jan Feng, who will tell you more about our portfolio in the mental health field. And I hope we'll have time for a few questions after each of the presentations.
In HEPRU, I lead the mental health program. I'll give you a bit flavor about what we do. So in this program, the primary aim is to produce evidence for cost effectiveness of innovation in mental health. Why we need those evidence? Because it's required by decision maker for health resource allocation. And also nowadays it's widely required by funding bodies in your grant application. I joined in the program and lead the program in late 2018, and I see the program of work is growing. These days we have 9 funded studies in my workbook. Our biggest funded is NIHR. We have 2/3 of projects funded by them, followed by Horizon Europe. Most of our studies are pool, RCTs, UK-based, and target for adult population. And regarding the disease area that our patients in those 9 studies covered is in a wide range. In addition to these 9 studies in my workbook, I also have 3 studies in the pipeline submitted to funders and waiting for decision. And I put the acronym of 9 studies in my book on the right-hand side only for your information. So apparently I can't do all the work by myself. I have a group of colleagues work in this program, either working at the moment or worked in those studies. We're growing, so as Bobby said, we're recruiting. So if you're interested, please do drop me a line. And also we work closely with our CIs or lead clinicians. Most of them are QM-based and a few beyond. So what health economists contribute in RCT? I'll give you a big flavor here, use my impulse trial. We usually involve in a clinical trial from the very beginning stage, which means the stage for preparing the grant application. For impulse trial, we were involved in the grant application and was successful and funded by Horizon 2020. I led the health economic package in this RCT. The primary aim was to produce evidence of cost effectiveness to evaluate an app-based intervention called Dialogue Plus. And the app has been implemented to treat patients with a psychotic disorder in a number of countries in Southeast Europe. And then from there, we involve in protocol development, we involve in data collection, data analysis. The result from the trial, from what I can see, is The treatment is not expensive, but it's not cost-effective compared to standard care. And then we also involve in the final stage of the trial, which means the dissemination activities. And part of the activity is to publish our cost-effectiveness paper in peer-reviewed journal. Here we publish our paper in European Psychiatry. This is part of our day-to-day job, working on randomized controlled trials. And also we got inspired from doing those work and developing our own research. I'll give you two examples of how I was inspired while working on the Impulse study. The Impulse study collects two types of outcome data, MANSA and EQ-5D-5L. MANSA is the primary outcome for effectiveness evaluation, and EQ-5D-5L is the primary outcome for economic evaluation. We're lucky here we can collect both types of data, but in many clinical wards, in many clinical studies, actually people don't collect health economic data. Only the primary outcome for the effectiveness evaluation data is collected. However, in many of those studies, they also require economic evidence. What we do then? One possible solution is you develop a mapping function, which means, for example, you only collect MANSA data, you apply the MANSA data to your mapping function, and you translate your MANSA data into economic data, for example, EQ-5D-5L. Apparently, it's not the most ideal. You won't really collect the data, but as that, many times it's not possible. So I look at the literature and see whether such a linking function is available, because that has practical use, can be practically used by other people. I didn't find such an algorithm, so I thought, okay, that's my opportunity. I actively looking for funding because Impulse trial completed in summer last year, and I look for various opportunity and see who might be interested. And one funding body was very interested in this idea. However, they're not interested in this particular relationship I'm looking at. They are interested about to developing a mapping algorithm for two instruments that are strategically important for them. They called EQ-5D-Y5L and EQ-5D-Y3L. And also they want to add in a piece of methodology work, which means in addition to produce this mapping algorithm, they also want a methodological piece to improve the method for the mapping exercise. So I thought, okay, good, yeah, that's really good for me. I really want it. So I joined the competition and submitted a bid. I resubmitted my revised proposal last month. So let's hope for a good outcome from there. Part of the exercise was to pulling a team together, and this is the team that I hope to work with. I'm the PI in this bid, and QM is a lead organization. I have a number of colleagues joining from Australia, not only researchers, but also high-profile collaborators from Australia and Netherlands. We are apparently very optimistic about the outcome. Despite having been confirmed about the funding, we have already produced our first methodology piece. So we're going to present our poster in 2 weeks' time in Rome, despite we haven't confirmed the funding yet. So the second, I will be very quick about the second one. So this is the second idea I developed from the Impulse trial. We're working on the data analysis. And I find very interestingly, the participant in this trial, remember they are patients with psychotic disorder. They reported quite good quality of life, at least use the health economic outcome measure. But not surprisingly, a large proportion of them reported being unemployed or claiming social benefits. So I really want to see how the income-related quality of life look like in this patient group and how that compared to patients that reported other type of chronic conditions. I use a data set I'm working on for another study with over 1 million patient level data record, randomly drawn from almost all general practice in England. I test this idea and a high level summary of my finding only in this particular question. I find in England, patients who've been diagnosed with mental health problem compared to other 9 types of commonly observed chronic condition, people with those chronic condition, and general population, mental health patient reported the lowest level of income on average, the second lowest level of good health status, and the greatest income-related inequality. So I add in this bit of analysis and result in my paper, which was submitted last month. So to wrap up, in this program, I see a growing research portfolio for mental health studies. The trials we work on provide a great opportunity for us to collaborate and also to develop our own researchers in-house. And also, we're working on the trials inspired further research ideas for both studies in methodological and applied area. Thank you.
Stay there, yeah. So we to take one or two questions if people have some quick questions, because you know, I think it's a bit more interactive. So any questions, Carol?
Lovely presentation. Where do you get income data from in general practice?
Oh, I merged the data with the IMD data.
It's IMD scores. All right.
Exactly.
So it's an area level method.
So it's a lower super outcome area. So
Yeah.
it's basically IMD for only one dimension of income. Yeah.
Any other questions? Okay, let's move to our second. Thank you, Jan. Our second presentation, Rungu will present one of the studies in quite a biggish project we finished recently. So, and it's a sort of how to use this one. I just use that
Okay.
one. Okay.
Sorry. Okay, hello everyone. I'm going to talk about a modeling study, which is the value of the cardiovascular disease or CVD prevention and impact on health inequality. We'll focus on studying therapy in the UK. This is a collaboration study across some universities such as Queen Mary, Oxford, and Sydney. Okay, we know CVD is still leading cause of morbidity and mortality, but its incidence and mortality has declined for decades in developed countries, including UK. Like the figure on the right shows, studying can reduce the low-density lipoprotein cholesterol or LDL-C, which is a major causal CVD risk factor, and thereby studying can reduce the CVD risk by 30 to 50%. And but study has unknown adverse effects such as on diabetes, on hemorrhagic stroke, and on muscle, but they are basically dwarfed by its benefit on CVD. And the studies are very cheap. So NICE recommend studying for all adults with CVD history, or those without CVD history but aged over 40, but with a 10-year CVD risk score over 10%. Which is measured by a score called Q-risk3 at this moment. For this study, this is the overview of the study. We developed a CVD microsimulation model. I have presented this model in my previous presentation in the Institute and the Center. Generally, this model is developed based on 600,000 individual participant data from large study trials called CTT and a cohort study called the UK Biobank. This model uses individual characteristics as input and can make individual predictions for patient. We also incorporate, this model will simulate these events in a random order and update the event history and the age annually until death. We also incorporate the study treatment effects with the evidence from CTT collaboration, and also incorporate adverse effects from trials and cohort studies, also individual estimates of the quality of life and the costs, so that we can use this model to do cost effectiveness and policy analysis. This model was validated in UK Biobank, which is an internal validation, and also validated in a separate Whitehall 2 cohort. We use this model to assess study treatment effects across all UK Biobank participants. The table above presents the net health benefits from lifelong standard studying therapy, and the table below presents the cost effectiveness generated by sex, age, LDL cholesterol level, and CVD risk. Taking one cell or one category as an example, men in their 40s with a relatively low CVD risk, as a P risk 3 below 10%, but with a moderately raised LDL cholesterol level. This category of people can gain on average 0.46 QALYs, which means a life year in good health if they initiate lifelong standard statin therapy. And with the cost per QALY gains is about £2,000. Women in the same categories gain 0.35 QALY, with the costs per QALY gain is almost £5,000. I'd note that the cost per QALY gains in all categories are well below the thresholds of the 20,000 to 30,000 that is used in UK decision making currently. So they're all cost effective. How to relate this research result to our studying policy? Let's look at the figure on the left. This is about the distribution of the UK populations aged between 40 to 70 years old by sex, CVD risk, and LDL cholesterol level. Blue represent men and red represent women. Let's focus on those in the shaded box. So these people, millions of people in the shaded box, they are not recommended studying by the current guideline from NICE. But we can say, however, more than half of them have a raised LDL cholesterol level. So on the right, using the same categorization and the coloring scheme are all simulation results. The length of the bars represents the range of the cost per QALY gains in these categories. And we can say the two solid bars in the shaded box it suggests that for people with a raised LDL cholesterol level, lifelong statin therapy is very cost effective for them, even comparable to those recommended studying by the current guidance. They are outside the shaded box, you can see. So the result suggests that the LDL cholesterol level should be considered in the guideline for statin treatment, but they are not at this moment. We also use this model to investigate the inequalities associated with CVD. There's a strong evidence that the prevalence of CVD and also CVD mortalities are higher, and the improvement in recent decades in CVD are slower among those more deprived people in the UK, and it's reflected in the expanding life expectancy in the recent decade. You can see this evidence. So we use this model to quantify benefits from lifelong standard statin therapy in accordance with the current guidance. The number in the horizontal bars indicates the percentage of people recommended studying by the current guidance. So we can say they're likely to be men, older, and more deprived because they have a higher CVD risk. And the model predicts, let's focus on the figures above. The model predicts the QALY gains per 1,000 individuals ranged from 70 to almost 500 for men, and 24 to 374 for women. And there's a we can say there's a gradient. Men, the older and the more deprived, tend to benefit more. However, in the figure below shows that more than half of the potential benefits are lost due to suboptimal compliance with statin therapy. We use the data from the UK Biobank to estimate the statin compliance rate here. However, the gradient pattern still remains similar. We can say because the older men and more deprived benefit more. So, what does the study tell us? So first, people in the UK between aged 40 to 70, they all can be considered for statin therapy because statin therapy in the evaluation, the statin therapy is cost effective for all of them, all categories. And people at a higher CVD risk with a higher cholesterol level and the more deprived tend to benefit more. People at a lower CVD risk gain less, but the statin therapy is still quite of very good value. And last, we need very good data, particularly participant data, large, to develop this model.
And a lot of research time.
Thank you.
So we can take 1-2 questions as well here. Any quick questions? Is it something what you expected?
What happens to people over 70?
Sorry,
What happens to people over 70?
Oh, because now we use the data only because from people aged between 40 to 70. But now we have another studies on the people aged over 70. So we are going to report it in a coming future.
But the big uncertainty there is impact of statin in over 70s. The evidence is much more limited. So it's consistent with the overall evidence, but there is more questions being asked there because, well, and there are 2 big studies underway at the moment that hopefully will sort of reduce uncertainty there. But that's the big uncertainty. So it slightly depends what the treatment effect are likely to be. Okay, but yeah, we have a work in progress paper there on that. So we'll tell you. Okay, any other questions?
Were you able to look at ethnicity in your study?
Not quite. So a lot of this work is based on UK Biobank. And ethnicity, I mean, there's not many ethnic minorities in UK Biobank. And it's a bit difficult even to use it to generalize to UK population. By what we've done we sort of standardize it to the population using age, sex, social demographic quintile there. But ethnicity, it's very difficult. It's not enough data even to allow this to be done reasonably reliably. So unfortunately, I actually should admit here, when we were designing this project, there was a question whether to use CPRD or UK Biobank data. But just before we sort of went into the designing of the study, I was sort of finishing a study on CPRD that it took 7-8 months to the researchers just to process the data and to clean it and so forth. And I thought, you know, if I don't find good people, it will take ages to do anything on CPRD data. So I was a bit scared to go that way. So we went UK Biobank way, which is cleaner data, much more sort of discrete characteristics of people, including diet and physical activity, actually, which are included in those risk equations there. Which has benefits because of this increased set of characteristics, but these benefits is that we cannot say much about ethnicity, for example. Okay.
Thank you, Bobby and the team.